A very good evening and a very warm welcome to everyone. This is Batul from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwarts who are present here with us today on this occasion of World Vitiligo Day. So, on this day, we are going to talk about the journey to understand and treat a skin disease. And to talk about this, we will be having our experts who will be here on a platform with us. Before moving on to that, let me just introduce briefly about the topic. Well, vitiligo is a complex skin disorder with significant psychological and social implications. Advances in understanding its pathogenesis and treatment options have provided hope for improved outcomes and quality of life for affected individuals. So, now without any further delay, I would like to welcome our moderator and speaker for today's evening, and he's none other than the very renowned Dr. Amit Jain, sir. Sir is MBBS, MD in D&L, dermatologist at Dr. Jain's Skincare Clinic, Pune. Sir is assistant professor at the Department of Dermatology, Venerology, and Leprosy at Bharati Vidyapeeth Medical College, Pune. Dr. Jain is a trained dermatologist with special interest in venerology, procedural, and clinical dermatology. His expertise area includes psoriasis management, eczema therapy, vitiligo treatment, autoimmune skin conditions, infectious diseases treatment, acne treatment, treatment for all other skin related conditions, nail disorder treatments, hair loss treatment, chemical peels, biopsy procedures, and the list continues. So now, without any further delay, I would like to welcome him at our forum and would like to hand over the stage to him for his precious talk to begin. So over to you.
Oh, hi. Thank you, Batul, for that very kind introduction. Good evening, everyone. Today, we are all here to talk about vitiligo, and today we are all here to talk about and spread awareness about the disease that is called vitiligo. Today is the World Vitiligo Day. It is the date 25th June. Vitiligo as a skin disease has existed, has been around since centuries. It has been mentioned in our history books. It has been mentioned in our religious texts as well. It has been mentioned in Veda. It has been mentioned in Bible. It has been mentioned in Buddhist texts and so on and so forth. It is an ancient disease. Some might say as ancient as the humanity itself. However, vitiligo or what we call safed dag sometimes can be confused with a lot of different diseases. There are a lot of stigmas, social, psychological, religious, personal, food related, genetics related, related with the spreadability, related with the treatment. There are a lot of misinformation. There are a lot of stigmas that are there that are present about this disease. And today, the topic of this talk and the aim of this day is to spread awareness about the various topics. As you know, 25th June, I will tell you a little anecdote. Michael Jackson, if you guys are aware, he was a very famous rock star. He passed away on 25th June 2009, and he was someone who was suffering from vitiligo all his life. So, in his to commemorate that, to commemorate his death anniversary, and to spread awareness about this disease that is so universal in our society, we started this World Vitiligo Day program so that we can spread some awareness about this disease. And to spread awareness about the disease, to talk about the disease, we have very esteemed guests with us today. I'll be introducing them to you. So we have Dr. Anil Ganju from Delhi. He is a very renowned dermatologist. He was the personal dermatologist for APJ Abdul Kalam. He has won multiple awards. He has been a speaker. He has had multiple publications, and he is really star-studded in the literal sense of the word. So I would welcome Dr. Ganju to enlighten us about the disease itself. And the second speaker would be Dr. Vicky Jain. Sir is actually a plastic surgeon and who has been dealing with multiple of these conditions and providing their surgical modalities wise treatment. So we would be going there and asking him a couple of nuggets from his knowledge, from their treatment experiences. So Welcome, Dr. Anil, sir, and welcome, Dr. Vicky, sir. I'm glad to have you here today, and I'm glad that we would be talking about vitiligo with your huge experience in the disease field itself. So, my first question would be to Dr. Anil, sir. Sir, you have seen so many patients. I mean, like you have ample amount of experience practicing in dermatology field. So, how has the experience treating vitiligo patient been so far? What is your experience? There are so many psychological, there are so many stigmas related with the disease. How treatable do you think the disease has been so far in the past coming years? We all know that there are a lot of modalities that have been coming up for these diseases. What your experience has been so far, sir?
Hello, Amit, and my fellow panelists, Vicky, and thank you, IGCP, for giving us this opportunity to be here on this platform on this important day for a very important disease called vitiligo, because it is a disease which has a huge psychological impact on the patients who are affected. And the disease is basically actually a genetic disorder which is actually untreatable, because the basic genetic tendency to disease does not go, although we can treat it to a large extent. And although there have been a lot of new inventions and developments in the therapy field, therapy for vitiligo, but we can only control the disease, and we can only treat it better though, but we can't cure the disease. But having said that, there are a number of modalities now that have developed in the recent past, not only to control the basic disease but also to surgically treat the leftover lesions or unstable disease, which Dr. Vicky is going to talk about. So, the newer developments in this field have been the availability of better drugs to control the autoimmune process, to control the spread of the disease, and better availability of the phototherapies, ultraviolet therapies, and the surgical modalities to bring back the pigment into the skin. So there is hope, and we look forward to better modalities to come in. But the patients definitely have a very difficult time with this disease.
Sir, are there any particular risk factors that are associated with this disease? Specifically, is there any particular age group or is there any particular gender-wise association that is related with the disease that you have seen
See, this
particularly?
is a genetic disorder. It is determined by the genetic predisposition to an autoimmune process, which, when gets initiated, leads to the damage and death of the melanocytes, which basically are the color-forming cells in the skin. And there is no predisposition to any gender, to any age, for that matter. It can occur in as early as the intrauterine life. There are cases where children have been born with this disease, and there are cases where it came the first time in the late geriatric age, in old age. So it can happen at any time in your life if you have a genetic predisposition. So there's no predisposition. And those who have a genetic predisposition, they can get the disease or get the aggravation of disease by factors like trauma, etc. Otherwise, there are no risk factors per se. So trauma can be a scratch, a lesion happening on the skin, or a kind of a burn where there can be an initiation. This is called cognirization, where the patients or people who are predisposed to the disease can have the development of that, or initiation or potentiation of the disease at that area.
Yes, yes, that is very true. So for us, the important point to pick up over here is that there is no gender-related uh, predisposition when it comes to vitiligo. There is no age-related predisposition when it comes to vitiligo. And basically, since it is a disease that is caused by a genetic propensity, so anybody with that particular sort of genetic makeup can have this disease basically. Sir, there are a lot of the times, since the disease itself is so old, certain people say that certain food articles, you should not eat something that is very sour, you should not eat something that is maybe light colored. What are your thoughts on that?
Now, this has been a very controversial, topic. And although when we started our practice, say around 30 years ago, at that time, vitamin C was supposed to, citrus fruits for that matter, were supposed to aggravate the disease. But then, further study into the foods causing or deteriorating or worsening the disease have shown that none of the foods have an effect on the disease. In fact, the vitamin C that was blamed earlier is now considered to be a good addition to the treatment, because it has antioxidant properties. And now we know that oxidative stress is one of the important parts of the pathophysiology of the disease, where the melanocytes are under the stress and get damaged. So we use antioxidants, we use vitamin C now, to take care of the disease rather than to protect the patient. So actually, no food is supposed to aggravate the disease now. We tell our patients they can have any kind of food in this disease.
Yeah, so again, thank you very much, sir, for that important point. We have seen this is actually the benefit when you have an experienced dermatologist like Dr. Anil with us, because he can tell us that is actually the fact. Previously, there were a lot of foods that were considered that they might be exacerbating the disease or they might be causing the disease, have now actually been proven to be much more beneficial than initially thought. So, yes, that is a very good point regarding that, sir. Thank you for enlightening us about that. The other thing, sir, that I would like to ask you is a lot of the times people sometimes are considering about sunlight. They wonder about what can be the role of sunlight when it comes to vitiligo. Can it exacerbate it? Some people think that if they're spending a lot of time in the sun, maybe they will not get vitiligo. What are your thoughts on sun and relationship of the sunlight with vitiligo?
Sun exposure is actually good only for vitiligo. That's one part of it. So in fact, we use a particular spectrum within the electromagnetic spectrum, which is the ultraviolet light, particularly the narrow band ultraviolet light. Yeah, am I audible?
Yeah, I think
Hello.
you were sorry, maybe need to repeat that because I think you got a little. I think there was some
Yes.
misconnection.
Okay, so in fact, we use a part of the ultraviolet B spectrum, usually the narrow band 308 to 311, for induction of the pigmentation. It helps by suppressing the immune response within the skin, and also stimulates the melanocytes, whatever leftover melanocytes we have, to produce pigment. So we use sun for the treatment of vitiligo. Having said that, people who have extensive loss of pigment can get sunburns when they are exposed to excessive sunlight. So, for example, a patient has extensive vitiligo, which involves the whole face. He is more likely to get a sun-induced damage, erythema, redness, burns because of sun, because his skin is not protected by the pigment which normally protects our skin from the sun. So, although it is beneficial, but one who has extensive vitiligo should not expose to too much of sun. But sun does not cause vitiligo per se. So there is a misconception that sun exposure would cause, or then sitting in the sun will prevent, is a wrong notion.
That's again very true. Sun exposure can play a role in the therapy itself of vitiligo, and it has been playing a role since historical times. Actually, we have used sun exposure and some sort of medicines along with that to actually amplify the effect of the sun in treatment of vitiligo. So yes, thank you very much for that information, sir. And again, yes, as sir said that extensively depigmented skin, if the vitiligo is very universal, if it has spread out a little bit, these people can actually behave like patients of oculocutaneous albinism and then are actually more prone to the damage that is being caused by the sun. So you have to be very careful, very specific regarding using the sun, the power of the sun, the what joules or what energy of the radiation that you are using. So thank you very much for that, sir. Sir, so regarding the treatment, and we are talking about the treatment, when the patient come to you, so what is your usual what's the usual process that you follow for a vitiligo patient? Like, how do you, because socially it is such a stigma to even tell a patient that you have vitiligo. Some people can be so sensitive about it that I think as a dermatologist myself, there have been instances where I directly did not want to disclose the diagnosis to the patient that it is vitiligo. So how to break it? How do you break it to the patient that it is vitiligo and it is something that is going? Because the first thing then you tell them vitiligo, they're going to be like, oh, this is safed dog. Oh, is this treatable? Oh my God, how did I get this? Did I commit past sins and past lives? And there's so many conversations and so many psychological factors come into the play directly. So what? How do you break it to the patient? Like, what's your take in that? How do
I
you
think
progress go
I
about
think
that?
at the I think at the first instance we don't need to be diplomatic about it. As a specialist, you have to give the true information to the patient. So I believe that
That
we have to tell them that they have this particular condition and they have to take it seriously, but at the same time give them hope that there's a lot that we can do about it. So the problem is why they are aghast when they hear about the news that they have vitiligo is that they feel that nothing can be done about it. So as soon as you tell a patient, yes, this is vitiligo, but don't worry, there are so many new things that have come which will help us one control the disease, to bring back the pigment. So you have to give them a little time and talk to them with concern and show empathy, hold their hands and give them hope that you're going to definitely take care of the disease. So I tell my patients that you're going to be all right. That part is not actually fully true also, although there are some areas which are difficult to treat. But then at that moment I tell them that you have this condition. There's no two thoughts about it. We have seen it with a wood lamp, etc., and we definitely know that you have this. Now that you have it, leave it behind, take it seriously. You will definitely you're definitely going to be all right. There are so many things we have at hand, right from medicines to phototherapy to surgery, that can definitely cure each and every part of your vitiligo. So have hope, take it seriously, take your treatment seriously, and be with us. You're going to be all right.
that is such a wonderful point that you have brought up, sir. Thank you very much for it. That yes, as a new practitioner, you must know that you have to be honest with your patient. You have to tell them what is going on. You have to tell them what's the diagnosis. But simultaneously, you have to be compassionate. You have to be empathic enough to actually understand that this can cause a lot of psychological trauma for them, and to provide support for that. I'm going to get back to you, sir, regarding the treatment of vitiligo more, but I have a few questions for Dr. Vicky Jain, sir, as well. Good evening,
I
sir.
think I think
Welcome to the.
high time you need to go to Dr. Vicky, because I was feeling that he's not speaking and he
No,
may be
no, no.
feeling
I,
bad.
I'm
You
fine.
know,
I'm
yeah,
getting more knowledge as it is.
no, no, I'm going to. Yes, I have a couple of questions for Dr. Vicky Jain,
Go
sir, as
ahead,
well. Good evening, sir.
please.
Good evening.
Welcome. Welcome, sir. You, sir, being a plastic surgeon, you must have such a unique perspective about treating these patients, and I'm so interested in knowing what your like. How do they patients? How like? I'm pretty sure that you must have done a lot of vitiligo surgeries. So many options are there. So how do you go about it? So like usually, with what kind of expectations are these patients coming for you, and how are you managing their expectations regarding vitiligo?
So basically, the patients come once they've completed the dermatological treatment, and the dermatologist has told him, "इससे आगे कुछ नहीं होगा." Now you might require a surgery. Your lesions are stable and they are not going to increase. And there was 6 months period I consider when they come to me. 6 months they're stable, but very important. A surgeon should know where not to operate. So with vitiligo patients in India, a dark patch is okay, but a white patch is a blemish. It is not acceptable, a social stigma. They are a lot psychologically affected. I decide my patients, I understand them, I talk to them, I talk to the treating dermatologist himself and ask him that is this a stable patient psychologically also? Because what happens, they have unrealistic expectations that the life might change after this. I tell them your life might not change. We can try to change the white patch. So there are a lot of things we have to understand before getting into the surgery, because surgery is the last resort they consider to be. After that, there's no going back. Once surgery is done, and if there is a bit of scarring, if the results are not good, they can fire back to you. The patients are any which ways in lot of mental agony. Okay, why they have been chosen for vitiligo? So basic treatments are there where you have to use your own skin. So the most common thing is autologous skin graft. We tell them we'll remove this. How it will look, it depends on your body. The scarring will also depend on your body. We are trying to give you the best possible treatment that is called autologous skin graft. We take a very thin graft, and then after derma abrading the affected area, we remove the superficial skin and with a derm abrasion, and then we put the skin without putting staplers or anything. We just apply the skin and apply a bactigras. We open the dressing after 5 to 6 days, and then we see, and then we tell the patient to do basic dressings if required, and in 5 to 6 days most of the skin graft is healed. Then we tell them sun protection is required. If sun protection not done, it will get darker. We have to tell the patient what presently it's a white patch, it will look much better than this. Right now it's looking white, that's why people are noticing you, people are commenting on you. After this might look a patch. If you want to hide it, you can say you got a burn and this has been grafted because of the burns. This is a double-edged sword because you are creating a trauma to the thigh itself where you're harvesting a graft. There also you can have vitiligo or you can have scarring. So we have to explain everything, all possible things. Recently, I operated a patient who had a vitiligo or a nape of neck, and she was very much affected with it. And to my horror, she developed a keloid when I put a graft there. So scarring was very dangerous, and that's what patient is right now taking Kinacot injections from me, and that is something worrisome. Second is a punch biopsy. We take small punches of the skin, which is ideally done by a dermatologist also, and they put that small punches in the vitiligo patch, considering the surface application, helping the vitiligo patch to go away. Then there is keratinocyte and keratinocyte and melanocyte transfer, culture transfer, which is rarely done in India. There are only few labs, if I know, I don't know anyone in Mumbai doing it. So we take that skin, we culture it. A small piece of skin biopsy is taken and is cultured and it's made huge. And with that, we can cover a large area of vitiligo patch. But eventually, I tell all patients that your results will depend on you itself. I am just putting the skin. How your body takes it and how your body accepts it is entirely depend on you. I can help you to get it better and better. But how it's going to happen, it's your body way. I can just tell them. Because scarring, we cannot predict. In the best possible patients, you can have the worst possible scars. That's it.
Again,
And sun
thank you
protection
so
is
much,
very
sir.
important.
Yes. Again, thank you so much, sir. I'm actually very interested in asking you multiple questions because I really want to get the plastic surgery perspective on vitiligo. Yes. So I'll be just talking about sir's answer a little bit. Sir has brought out some wonderful points. I would have to give it to him. He has brought out some wonderful points. First thing is that the vitiligo needs to be stable. The stable vitiligo is obviously something that has not increased in size since the last 6 months. Some people will even say a year. That definition might vary for different people. So that vitiligo needs to be stable because as Anil sir talked about something called as kibnerization. Because in vitiligo, in active vitiligo disease, there is a risk of kibnerization. As Vicky sir also emphasized that if you are taking a skin graft, if you are taking a skin graft that you're going to be grafting, there is a risk that that patient may develop vitiligo on that particular site. That is a very prime example of kibnerization. So you would have to obviously see that the first thing that the disease need to be stable. As sir talked about it, that obviously you need to collaborate with the treating dermatologist for vitiligo who is treating the disease. That is very important. Again, a very important point of view that has been brought up by sir. It is very important. There needs to be some kind of collaboration for proper treatment because then you would know how severe the disease has been, how active the disease has been. Is it dormant? Is it inactive? Are there any risk factors that can be leading to the exacerbation of disease rather than the remission of the disease itself? And the third point that he brought up very importantly is managing the patient expectations because yes, that the patient has been suffering a lot, They have been in a lot of mental, a lot of psychological and emotional trauma regarding the disease itself. And since, as Vicky sir said, and before that, Anil sir also said that how chronic vitiligo can be, because it is basically a tendency. It is something that is that is more like a genetic tendency that is there. So it goes and it comes back, and sometimes it may come back again. So the patient can get very disappointed and very frustrated with this disease. So managing the patient expectation, what your patient is expecting from you, are their expectations right? Are the expectations being managed? Are they manageable to begin with? And how to correct those expectations in a manner where they are still willing for the treatment, where they are still willing to go for the treatment and not being completely disappointed. That is really something very important. He talked about surgical modalities. He talked about split thickness grafting. He talked about culture melanocyte grafting. I would like to tell you that we don't do culture melanocyte grafting, but we are doing non-culture melanocyte. There are kits and all that are professionally available, and we are actually doing it in our institute in the cases of stable vitiligo. So that is something that yes. Sir, Vicky, sir, the other question that I would like to ask, like, if you you operate these patients, sometimes the certain areas are going to show a better result, and the certain areas might not show a better result. Do you have any comments regarding that? That what areas would show a better result if they are undergoing a vitiligo surgery, and what areas might not show that good of a result while undergoing vitiligo surgery?
So maybe the forearms and arms, certain areas like limbs can give you a better results. But sometimes when you do it over the chest or maybe nape of your neck or back, that's where you can get keloids and hyperpigmentation more of it. So the best areas to operate is your limbs, where you can get good results. I have got good results in the limbs, but not on the chest. So I'll tell you, way back, a person was wanted to get married. He hid it from his wife that he had vitiligo. So before one month of the surgery, before 1 month of the marriage, he got a vitiligo patch covered over his chest, and he got went to his village, and then he came back to me. He's like, sir, this is looking hyperpigmented and a bit thickened. So I told him, after surgery care is very important. You need to use placentrix gel, and you need to massage it with moisturizer. And sometimes you need to, once you put a skin graft, you need to use silicone sheets also, that they don't get hypertrophied, they look even to your skin. So scar management, once you have put a skin graft, it can cause scarring also. The scarring has to be taken care of the same. So I would suggest the limbs are the best place, and they are mostly hidden also. But chest
Yeah.
is also hidden, but they can cause bad scarring. So the results are not that much better, I suppose, on the chest and the back.
Thank you, sir. As sir, like one tendency that we have been recurrently talking about is that I would like to clear out is the keloidal tendency that sir has been talking about, and sir has given us multiple examples regarding how it can be so important to identify the tendency in certain patients, that if they have the tendency, and how it is very important to know the areas that are more prone for keloidal tendencies, like sir talked about back or the scapulary area or the chest itself can have a lot of keloidal tendencies sometimes, and these patients can end up with keloids that you would need to treat secondarily. Yes, so that has been very important. I have a question for actually both of you, Anil sir and Vicky sir. A lot of the time, these
I think
a
we
lot of the times they're coming for something
lost
like,
Dr.
oh,
Amit.
yeah, am I
Yeah,
audible now? Yeah.
Yes, please.
yeah,
Huh.
yeah.
So a lot of the times these patients are saying that, oh, they are going to get married or they are going to start looking for spouses. I have had patients who would be like, I have this vitiligo patch and I'm planning on getting married in like 6 months, 8 months time, and I want to start treatment for it. So, and I am
Vicky has a poor
treatment
connection. Amit has
itself.
a poor connection.
Amit Bhai is right.
Sorry, I
I
don't
am.
know why is that.
Yeah, yeah, Amit has a
I
poor
have no
connection.
idea why that is happening. I'm sitting in full Wi-Fi range, but I have no idea why is that happening. Am I audible now?
Yes, yes.
Yeah, surely.
Yes. Yeah, so my question was a lot of the times these patients are coming who are about to get married, who are planning on something big event in their life, basically marriage or it can be something else. And they are planning on hiding that from their significant other. So what is the physician responsibility here? If they sometimes they ask you to lie, like I have had instances or I have seen my colleagues having instances where they have gotten the other side and they are asking them, like, can we figure out if it has been treated or can be figured out if he has hidden something from you. The medical legal aspect of it, basically, that I'm talking about. What is our responsibility there? Like, how how do we deal with it?
So basically, I tell my patients not to hide it from the spouses, to be spouses, because I consider divorces have been very common of late. And what happens is people don't tolerate each other. So the thought process is that this guy has cheated me by hiding something. You have to explain your spouse, the person, that this is not contagious. This might happen to our offspring, but the person who's accepting you with all your faults is the best person to get married with. The problem is if you don't tell them, you can land into a lot of problems. For at least males who are hiding it, they can have a tough time to get a divorce, and maybe it can be very, very this thing. So same guy I'm telling you, the chest guy, he had a lot of problems, I suppose, and he cursed me. Okay, the results are not good. That's why I'm going through a divorce. I told him you should have told your spouse this bounces back. That's why the patients bounce back, and that is a very difficult situation to treat it. And he haunted me for 3 to 4 months, and I told him, I cannot help you. It was your choice not to tell your wife. It was not my choice. If you would have told, I think she would have not get married and you would have not got a divorce. This is your call. Yeah.
Yeah, definitely. It's their responsibility. Definitely, they should tell. Sir, Anil sir. Now moving on to you, what has your experience been regarding this spousal confrontation or hiding from the spouses the fact that they had vitiligo, and how do you think a physician's responsibility lies there? Like, what should they do about it? How do you deal with something like that?
I agree with Vicky, and in fact, even the people who have had vitiligo, who undergo a surgery, and everything is, taken care of, and then they go for surgery, even they should disclose, because vitiligo is something that can come at any time in your life. So they should be told about this possibility. There's a possibility that it can come later, and then it can trouble you at that time. So you better disclose. And if you have it, don't try to hide it, because as Vicky said, it can be quite detrimental later on. So I think you have to tell your patients that I tell them to be sincere in this.
Yes, yes. I think that is very important, and I think it is very important for us as physicians to be basically staying away from giving them all the information. While we need to give them all the information, we need to try to nudge them towards the right direction. But you can only make the horse see the water. You cannot make him drink it, as they say. So yeah, I think that was because I think practically that is a lot of the times we have. I think we all have faced that issue regarding these patients. So, Anil sir, my next question is to you. When you start vitiligo therapy to the patient, what's your usual modality? Like, what do you like? Have you seen? There have been a lot of changes, right? From moving on since you have been practicing, you have had a fantastic practice from really quite some time back. So, how the treatment has evolved? What would you like to comment regarding that about the treatment of vitiligo when it comes to medical modalities?
Although there are so many new drugs that have come in, they are relatively safer than the drugs that we would use earlier, for example, steroids, etc. But then the two components of the disease remain the same. The way we treat the disease remains the same. When the patient comes to us for the first time, we have to work up the patient very extensively, take a good history, make sure about the disease activity, the extent of the disease, whether it is spreading or not, whether new lesions are coming or not, and then we decide upon the therapy. So the disease, if the disease is stable, is unstable, is spreading, so medical therapy becomes very important because you need to control the autoimmune process. So at that time, you have to give them, immune suppressants, and I think steroids are the best, although you can't use it for a long time. So we have other drugs available which are steroid sparing agents, so but they take time to have their effect. So usually we start with a steroid, maybe daily, maybe on a pulse therapy, but at the same time we combine a drug that we would continue for a longer time, maybe 3 to 6 months, until we control the disease completely. So we generally combine these newer drugs with a steroid and taper off the steroid after 2 3 months once the new drug has taken over, and then continue it for another 6 months to a year, or whatever the patient needs. That way it has become easy, because steroids cannot be given for a long time. Earlier they would need to be given for a long time. So we have newer therapies, we have so many new options available, and JAK inhibitors, Janus kinase inhibitors, are
Hmm.
one set of drugs that has really made a huge difference. Now they are relatively safe, although you have to give them carefully. Unless you're trained in using these molecules, they should not be used. But then you have even topical ones available now. For example, ruxolitinib, which is a topical JAK inhibitor, which has shown a lot of promise. It has not come to our country as on now, but it's available in the West.
Crisaborole is there, but how have your experience been with
No,
topical
crisaborole is
crisaborole?
not a primary drug for this condition. It has been approved for use in eczemas, atopic eczema, etc. Although it has
Mm,
been used in this condition also, but not a primary drug for this. But JAK
not a
inhibitors
primary
definitely,
drug for this.
yeah, JAK inhibitors.
Definitely. Uh, so, sir, while you are screening these patients, as you talked about, that you need to do the extensive basic research, basic blood workup, basic investigations before starting the treatment for these patients. Are there any particular conditions that are associated with vitiligo that you are looking for that you maybe need to rule out along with vitiligo? Are there any particular conditions that you're suspecting that these patients might have?
So you see, all patients who have an autoimmune disease have the possibility of having other autoimmune diseases also. So many of them will have an association with, for example, thyroid disease. They can
Mm.
have other autoimmune diseases like pernicious anemia, etc. So although we don't need a extensive workup for vitiligo per se, but you may do a few tests to find out whether there is an associated autoimmune disorder or not. Then the investigations come handy for when we initiate therapy or we are continuing therapy, because most of the treatments will have side effects, and most of the treatments need an extensive workup. For example, the JAK inhibitors that we are talking about, so we need to do a thorough blood count, do a LFT, RFT, do viral markers. That's very important, and exclude the tuberculosis, exclude dormant tuberculosis, which is very common in our population,
Country,
this
yes.
part of the world. So we need to do extensive workup for giving the treatment rather than for vitiligo per se. So vitiligo is a very direct diagnosis, a very clinical diagnosis. You don't need to do a biopsy. You can definitely, just a wood slamp examination will tell you that the patient has vitiligo. If you at all you have doubt, which is very uncommon, you can, a naked eye can easily pick up vitiligo, but sometimes there is a little doubt which is helped by a wood slam. You rarely would need a biopsy, and no blood tests per se will help you in diagnosing or working up the vitiligo. But then the therapy needs a lot of investigations.
That's very true. A few very good points made by you there, sir. Definitely, you need to investigate for the autoimmune diseases because, as they say, the autoimmune diseases, autoimmunity, they run hand in hand. So you need to rule out something like pernicious anemia, thyroid, or maybe sometimes even they might have type 1 diabetes specifically if the patients are very young, more likely in those cases. And as we talked about, that tuberculosis is something that is endemic in our country. So while if you want to, because we will be moving out from more trusted modalities like steroids, because obviously they have significant side effects associated with them. So yes, we do need to see that. So talking about biopsy, a lot of people have very mixed opinions about the biopsies for vitiligo. What are your thoughts regarding skin biopsies for vitiligo patients?
I don't think it has any role except they use it for assessing stability in when they are planning a surgery. So otherwise, biopsy also when you are very not very sure about the diagnosis. Sometimes the lesion may not be completely depigmented, but then you suspect. Then you may do a biopsy. But otherwise, biopsy generally is not required to diagnose vitiligo.
Yes, that's true. That has been since like I have recently passed out. That has been a very common question of the examiners regarding the role of biopsy in vitiligo, and as Sir has explained it very beautifully that it's not really needed for the diagnosis until and unless you're trying to rule out something else. Vicky, sir, how have do you do the biopsies to screen the patient for stability of vitiligo? Like how what's your process regarding doing something like a skin biopsy for
So
vitiligo
mostly the
patients?
patients come from the dermatologist. They have extensively worked up, they extensively treated, and I always send the patient. If in case the patient directly comes to me, I send it to a known dermatologist around. I ask him and understand the history of entire thing, and if you think, then we go ahead with the surgery. If there is any red flag, I do not go ahead with the surgery because surgery is somewhere irreversible. And if it gives unhappy results, unwanted, unexpected results, it can be difficult for me and for the patient to cope up with. That's why I select my patients. I'm telling you, in cosmetic surgery, the problem is yours. It's not in the patch.
Yeah,
So we have
yeah,
to
yeah,
decide the patient, and we can send the patient to your the best friend. Or if in case you think that there is a red flag, refer him. You tell him I might not be able to give you the best possible results. You can send them to your patients to some other plastic surgeon and preempt him that this patient might come to.
true. I think patient selection again, the role, like the properly worked up patients are very important. I think specifically when we are going about surgical modalities for the treatment of vitiligo, the properly worked up patients, the properly treated patients, because that establishes the stability, and then that way we can avoid unnecessarily invasive procedures like skin biopsies, specifically in this case where it might not show certain benefits. Sir, Anil, sir, we were talking about immunosuppressants. So, we have used, dermatologists have used a lot of steroids in various formulations, mini pill, oral mini pill therapy, mini pulse therapy, or the other therapy. So, what are your thoughts regarding other immunosuppressive agents? Say, like, what would you prefer, like, among other ones, apremilast, azathioprine, methotrexate, cyclophosphamide? Like, what's your usual go-to? What is the most trusted molecule that you have the most experience with?
Well, steroids, of course, and then azathioprine is quite a common drug that is given along with the steroids initially, and then the patient is kept on azathioprine for a long time. Uh, Even methotrexate, and now we are quite well versed with these molecules. Earlier, we used to be a little skeptical using these, uh, you know. Uh, Basically, they are cytotoxic drugs, and we would not be very comfortable using them. But now we are quite experienced. There's a lot of literature supporting their safety. In fact, methotrexate has become so safe now that it's so extensively used even in children. So we are using them more and more extensively, and they're really helpful in controlling the disease, and at the same time avoiding the side effects that would happen with steroids earlier. So you may give steroid for a short period of time, maybe a month or two max, and particularly now we give it in a pulse form, and then meanwhile make the drug start working. It takes about 4 to 6 weeks for these cytotoxic drugs like methotrexate, as azathioprine, etc., to have their effect, and then they take over. Drugs like apremilast are not primary drugs again for vitiligo, but when you have problems where you may not be able to use because of any contraindication the other drugs, then apremilast is an extremely safe drug amongst these. Immune. It's more of an immune modulator. It's a small molecule biologic, as it is called, and has the advantage of given orally. So that makes it a very useful drug. But then I don't use it as a primary drug. I may use it where I'm not able to use other drugs. And of course, JAK inhibitors have become very, very useful now. And although again, they have to be given carefully, we have to work up the patient properly and keep the patient on constant, vigil. Do their investigations at regular intervals, because it can cause problems that way. Otherwise safe set of drugs. They have been given for tofacitinib. We have now experience of up to 11 years in juvenile arthritis. So not on skin disease. In fact, it is not US FDA approved for skin disease. Only for psoriatic arthritis, juvenile arthritis, and rheumatoid arthritis is that it is approved. But off-label, it is being used extensively, and there's a lot of literature now where these JAK inhibitors are helpful not only in vitiligo but in a number of other autoimmune conditions also.
A lot of actually the immunosuppressants, as sir beautifully said that pointed out regarding the various drugs that azathioprine and methotrexate, that there is obviously a period after that they are going to start acting. So you need to cover that period with certain other drugs. Meanwhile, they are taking over, and then you need to replace those drugs. And also the safety profile that he mentioned, that you need to do the workups with azathioprine, with something like methotrexate. Although huge experiences there have been with these drugs. Although again, as we were talking about, these none of these drugs are actually US FDA approved. Neither methotrexate nor azathioprine for treatment of vitiligo, and all of these are actually off-label indications of these diseases. Talking about the genus kinase inhibitors, JAK inhibitors, tofacitinib in particular. Sir, have you experienced certain peculiarities when you're treating patients with tofacitinib? Specifically for vitiligo, have you noticed that it regarding the dosing, that you need to give it for a longer duration of time, regarding the relapses, regarding the safety? Have you had any latent tuberculous reactivation? As I think people so many times are just concerned about. We are doing IGRA, we are doing MON2, we are doing chest X-rays to rule out if there is any latent tuberculosis infection. Sir, what are your thoughts regarding tuberculosis and tofacitinib?
Well, I haven't come across a reactivation, but I have many friends who have had reactivations in their have the experience of reactivations with tofacitinib. But I have come across many patients who have come out to be a positive IGRAs, and they never knew that they had tuberculosis ever, or they were exposed to any kind of tuberculosis, and they come out to be positive on IGRA. And many times we need to give a prophylactic, because we want to give tofacitinib, then we give them a prophylaxis of tuberculosis for a month or so, and then start the JAK inhibitors. But fortunately, as on now, I have not got a reactivation, but I know a few friends who have seen reactivation of tuberculosis happening.
So it's quite a real concern then, because I have not seen any reactivation, but yes, it is quite a real concern. Reactivation of tuberculosis is quite a real concern, and IGRA positivity and the treatment of that. Again, anti-tubercular treatment can be very. It can be. You need to take proper precautions, and you need to refer them to. So, do you refer these patients to like the tuberculosis, particularly pulmonologist, or
No, no,
like how does?
there are specific standard guidelines as to how we need to give prophylaxis. We give two drugs for 1 month, and then we can start the JAK inhibitor and continue the two drugs for another 2 months after that, and that takes care of the reactivation. It does not allow the reactivation of tuberculosis.
That's a very important information regarding how to thank you very much, sir. That was a very important piece of information. Sir, what about the relapses with tofacitinib? How long do you usually give tofacitinib for if you have to continue with
Usually,
tofacitinib?
about 6 months is when I would want to taper off the drug and see whether the activity is gone. In most of the patients, the activity has been controlled by about 6 months, and then we taper off and slowly try to stop the medicine. Relapses are common. Many patients will have relapse, and but many of them may not have, also the lucky ones. But I believe that 6 months of immune suppression is a good time to find out whether the patient has got decrease in activity of the disease, and then you taper off slowly and then check on the patient, keep the patient on constant follow up. There is a possibility it might come back. If it does, then you retreat. If it doesn't, then we just treat the pigment part.
That's true. Tofacitinib, although very effective, has been known to cause, if you're tapering it very quickly, has been known to cause very quick remissions of vitiligo. So that's an important part regarding the treatment and how you need to watch out for repigmentation. I will ask one last question regarding tofacitinib, sir. Do you combine it with any other medication, like how you would give steroids with maybe how you would give mini pills with another immunosuppressant that will take over? Do you combine? Do you like to combine? Have you combined tofacitinib with other drugs, or like do you like to give it solo? Because there is
I have,
allegedly risk of
yeah. So
yeah, because
generally there is a belief that two immunosuppressants should not be combined. But now, uh, uh, in the recent past, there have been instances and there have been a number of studies where they have combined some immunosuppressants, lowering the dose of each, which the logic is that you get the best out of both the drugs and reduce the side effects of both the drugs. So even tofacitinib is now extensively used by rheumatologists in combination with methotrexate, and I have also started
hmm,
using. So they give 11 milligrams of extended release tofacitinib along with 7.5 milligrams of methotrexate once a week. So this I have started using in many of my psoriatic patients, not of vitiligo per se, but in many psoriatic patients I have combined it because methotrexate is a very good drug for psoriasis also. So combination works well, and these patients do well. There are hardly any side effects, and I have several rheumatology friends who now vouch for this combination and have been using this in most of their patients of autoimmune disease.
oh, all right, sir. That's actually, yeah, that's good to know that. A lot of the times, new practitioners, because a lot of the time practitioners, tofacitinib is new, and definitely it's a newer drug for Indian dermatologists, and a lot of the times, a lot of the practitioners that are practicing dermatology specifically, they are not so sure about using something new until unless they have read extensively towards something like that. Specifically, something like tofacitinib, the drug combinations and the how to combine it can be people can be very concerned about that. So that was a very good piece of information. Thank you very much for that extensive knowledge about tofacitinib and the drug therapy and vitiligo. I'm going to go to Dr. Vicky, sir, and I have a couple of questions for you as well, sir, regarding the vitiligo surgery that you have been performing. Sir, do you usually start directly with vitiligo surgeries, or there are initially like some other maybe chemical cauterization or certain other things that you like to like advise these patients to, or like how does it go?
So basically, when the patient comes to me, he has been, I exactly tell you again that I do not do any cosmetology per se for vitiligo patients. What anything medically or anything has to be done will be done. Small procedure also. Even a pulse biopsy has to be done. And what he says, we keep blister biopsy is done and then topical patch. These are the surgeries mainly done by the dermatologist in Mumbai also.
Yeah.
So I tell them the patient comes from dermatologist. I explain them this is surgery we are planning. We are trying either a pulverized skin graft. Pulverized skin graft is used. It is a very thin graft. You just make a paste of it with saline and just apply it. One part is that, or we use a autologous skin graft where you use the thin graft and you just apply the skin graft like a normal graft. So either which ways you're transferring melanocytes. So that's what it is and causing pigmentation. I
Sir,
tell them this is
yes, yes, sir.
I do
Please
this
go ahead.
surgery
Sorry. Yeah.
and then follow up with them. Most of them get good results, but somehow they get some halo effect. Halo effect is when you put a graft and the surrounding is a bit white. That is something which patients don't like. I tell them I try to go in the normal skin also, but once I put the graft on the vitiligo patch and a bit of normal skin, there will be a bit of depigmentation surrounding the graft. It is common. That is called halo effect.
Yeah. Okay, yes, yes. So you need to counsel the patients regarding such obviously. side effects. I mean, like, they are
Results.
basically something that is, yeah, part and parcel of normal procedures. Sir, so if a patient is coming to you for vitiligo surgery, like how long is the hospital stay usually for them?
It's a
Like,
daycare surgery.
does it,
It's a
it's a day?
daycare surgery. So
Hmm.
if I'm putting graft also, I would not go more than one thigh because the
All right, yeah.
patient will come in the morning, get the surgery done in 2 3 hours. He should be worked up before the surgery, before getting admitted. Once he's worked up, everything is fine. I send the reports to my anesthesiologist. My anesthesiologist says yes, he gives me a thumbs up. We can go into the surgery. I admit the patient morning itself. I get the operating, and then after the surgery, 6 hours he has to be 6 or 8 hours he has to be nil by mouth. Once he tolerates his liquids and solids food, he can go home because any which ways his dressing needs to be changed after 4 to 5 days, maybe 7 days sometimes. So there's nothing to worry. I tell them the pain will be more towards the thigh where we remove the graft rather than the place where we operate, where the patch was. Because here we create a iatrogenic abrasion, what we say, and that is very quite painful. For that, sometimes patient bother us, so we apply a buprenorphine patch, which will make sure that the pain is tolerated. And he comes to my clinic after 5 to 6 days, and then that's where we do the first check test.
Sir, does it vary? Like, if you're suppose you're doing grafting on, or if you're doing certain on movable parts, like something say around the lips, or if you're doing around the eyes, does the care changes, and how does it change
The
for
care
the?
changes, we normally apply a bolster dressing. Bolster dressing makes sure that the graft is not moving. So if this is a graph we apply a pressure bolster like thing and then we suture it over and above. The bolster makes sure that the graph is not moving. If you're doing to the hand anywhere, we give them a plaster in a anatomical position. If we are putting the graph here somewhere, we give a cock up splint also that it is not moving. The chest is very difficult. So the chest and the abdomen is very difficult, but for that we give a pressure dressing to make sure that the graft is not moving.
The immobilization is
Is a
very
very
important,
integral part of the dressing.
very, very important. Sir,
That's
during the dressing, like, do you use any particular sort of dressing to increase the melanocyte transfer from the graft to the affected parts, or to for the better healing or for better cosmetic results? Do you have any particular comments that you like to make regarding this?
ba- basically after surgery, once you put the graft, there's something called as Bactigras. It's a paraffin
Hmm.
chlorhexidine gauze. So we apply that directly to make sure the graft is a bit hydrated. It should not dry because for the first 24 to 48 hours, the graft doesn't have its own blood supply. Slowly, it takes the blood supply from the bed. So for that, we require that, and then we put a betadine soakage cotton, which makes sure that if there is any soakage, the betadine soaked cotton absorbs it and doesn't cause a small hematoma, which will cause graft loss. And that over that we put a bolster dressing or immobilization. Pressure is a very integral part. After the surgery is done, after 5 to 6 days, we see if the dressing is good. We do new dressings maybe in after between 2 to 3 days. If the graft is well settled, after that we tell them moisturizing is a very important part of it because of if moisturizing is not done, the skin will tear apart again. It will have scaling, it will get dry and it can cause problem. Placentrex, I have been using it during my residency days, way back in 2013 to 14, 15. So that's where we use. I don't know genuinely. I would say any basis of it, but it has given us results, and that's why we're using it. We tell him to massage with it, and pressure garment is also important to avoid hypertrophic scar and belt injury.
So I think you were talking about silicone sheets as well. I think,
Yeah.
sir, how effective
So
are the
silicone
silicone sheets, and how easily available
silicone
are they? I think a lot of the times, I think what patients have faced issues with are the availability of silicone sheets and stuff. Like, are they very easily available at particular? Like, how do you make sure
so
that that?
it's difficult to find a good silicone sheet. So basically, we have vendors. We give them the patient the number. We tell them buy it from them. or you find it somewhere, you send me the photo or maybe the brand name. I'm okay with it if it's good. So the most common brand which they get is a Sika Care, which is quite expensive, maybe 2,600, 700 for a 6 by 12 centimeter. So I tell them better to buy it from a vendor. A vendor might give a large sheet at a lesser cost. And silicone sheet, I tell them it's self-adhesive, reusable. It increases the blood supply by causing hydration, by getting more blood. By getting more blood supply, you get better growth factors or better healing, better, less scarring. I would say that silicone sheet,
Yeah,
and
I
over
think,
that a requirement is that Sone Pe Suhaga thing, which will help you get better results.
and it helps you to get better results. And do you, after you said that avoiding sunlight is important for
Yeah.
avoiding the hyperpigmentation. If the halo and all that is there, can you use localized? Do you like prescribe them localized phototherapy that they can go to a dermatologist and see eczema, laser, and all that?
Yes, yes. I tell them, oh, we have treated your disease. For the cosmetology part, I do not have lasers. I have a fellowship in laser surgery in from Mumbai only. But I suggest them to go to the dermatologist. They are the best people who can handle skin. You have come from a dermatologist, please go back to him. You have come for a purpose to me for the surgery. I have done the surgery. I think it's good. For the remaining part, dermatologist is the best person who can help you.
Actually, thank you, sir, for that knowledge. I think the couple of questions that I would like just, I think we are just at the end of the session itself. I'll just ask a couple of questions. I have some questions. If we're talking about phototherapy, Anil sir, what are your thoughts about these handheld excimer lamps and handheld phototherapy units? Do you prescribe them to the patient for repigmentation purposes? How has your experience been with them so far?
The experience is not very good, but there are patients who have no access to even sunlight. For example, people who are busy during the day cannot take it and can't come to the clinic also. Then we do give them the handheld, particularly if there's a localized disease. But then if they have an extensive disease, generally they do not get very good results with these handheld devices. But the handheld targeted phototherapy, which is excimer light that we have in our clinics, it's wonderful. It's very good. Much
Examer has been
excimer
quite
light
a
to the,
game. Yeah,
yeah. It definitely within 4 or 5 sessions you start getting pigment with that light. So it's very good, but that's not the one that the patients take for their home use. Generally, that we use in our clinic
mm,
only, targeted for localized lesions. But for handheld, generally they do not give very good results. Probably the
they have
patients are
not.
also very serious.
Mm. One more thing, sir. Regarding the treatment of vitiligo with phototherapy, there has been some debate regarding treating stable vitiligo and unstable vitiligo. A lot there have been what I have noticed. There are two different thought processes. Some people will say that only treat stable vitiligo with phototherapy, while other people will say that treat every vitiligo with phototherapy. It will start the pigmentation. It will start the immunomodulation. What are your thoughts about uh, treating
Definitely,
stable versus unstable vitiligo with phototherapy?
narrow band UVB therapy not only induces pigmentation and induces the melanocyte to produce pigment, it also has immunomodulatory effect. So, I believe that you can start, narrow band UVB therapy right from the beginning, along with your medical therapy. It helps and works synergistically with the medical therapy. Earlier, when we used to use Puvasol or Pua for that matter, that did not have much of an immune modulatory effect. It would just cause sensitization of the skin to ultraviolet A light, and that would just work on the pigment part. There was some logic in waiting for the skin to get disease to get stabilized, give immunosuppressant, stabilize the disease, and then give. Now it works synergistically because it has immune modulatory activity. The narrowband UVB affects the immune system and suppresses the T cell activity. So it's
Again,
a
a
good
very
idea.
good point. Yes, definitely. So, very good point made by you. Two different light therapies that we are giving according to different conditions. We can use them. NBUVB, very well explained. Thank you very much for that, sir. Usually, how do you give NB? You have like photo chain, like you have these light devices that you give, or like do you usually because a lot of the time these private in private practice, a lot of the people don't keep these UV chambers and all that. What do you like to do for that, sir?
I
Do you
think
usually?
it has to be a very important part of your practice because vitiligo forms a good chunk of your practice. And when I did my initial training with Dr. Sawant, at that time vitiligo surgery was a rage, and he would tell us that you have to start with at least electric cautery. At that time, we would not have radio frequency, so electric cautery, a UVB chamber. These two things are very important part of to start your practice. And UV chamber adds to your gives you the complete therapy for your patient, and then also builds up slowly the patient pool who will finally go into surgery, because at that time surgery was a craze, and we would do a lot of punch grafting at that time. But now we have evolved into non-culture melanocyte grafting, etc. But I have full body chambers, two of them, half body chamber one. They are all now narrowband UVB. Earlier, I used to have one PUA chamber, one narrowband UVB. So they now, and I have targeted phototherapies at least 3 or 4 units now.
Oh, yes, I think that does constitute a complete package for the treatment of vitiligo, because in dermatology practice, vitiligo patients can contribute a lot. I think we are. I think do we have? Okay. Doctor Vicky sir has to leave, I think. Sir, is there
Yes,
anything
doctor.
else that you would? Yeah, I think he had some emergency and he had to
I
go.
think the final message that patients need to look at the hope that is provided with the therapy in vitiligo. They need not lose hope. There is a good percentage of patients who get completely all right with the present day medications that we have. There's a very small chunk who are left out, who may need surgical treatments or who may need camouflage, etc., covering up the remaining lesions. But that doesn't mean that they have to give up hope. So hope should always be there, and we are always there to help them.
Thank you very much, sir, for such an informative session. I think I learned so many things from you. Thank you very much for the information that you
Thank you, Amit.
provided.
It's a
Uh,
pleasure.
yes, it was an absolute pleasure, sir. So I think with this, our conversation for the Vitiligo Day is over, and I think I'll be handing over the chat to uh, Batul. Batul, are you there?
Yes, yes, I'm here.
Uh, yes,
Yeah,
I'll be
thank you
handing
so
over the chat to
much.
you. Yes.
Yeah, thank you so much. Thank you for your amazing talk and the discussion that has taken place on our platform. Thank you so much for that. We were thrilled to hear you out in the backstage when all three of you were discussing about this particular topic and making our viewers understand about it. Most of the important questions were already covered. So thank you so much for that and for giving us this opportunity to hear out from such renowned experts. So thank you so much. With this, I would like to conclude the session here for today. Until next time, and we hope to see you soon. Thank you.
Thank you very much. Thanks a lot.
Thank you, sir.
Thank you.
Thank you,
It's a
Batul.
pleasure.
Thank you, sir. Thank you,
Thank
sir.
you.
Good night. Bye bye.